Hi, everybody. First, let me thank the organization committee for the invitation, especially the president of the society, the Tunisian Society of Cardiology, and Professor Rania for the invitation. Today, I will talk about the new EBC consensus document, which talk about many strategies to protect the side branch while we are stenting the main vessel. My name is El-Ghali Mohamed BENNOUNA, and I work as an interventional cardiologist in Casablanca in the University Hospital. So every time we talk about bifurcation PCI treatment, we need to know that it's always a challenging cases. Why? Because anyone who performs PCI in bifurcation, especially complex bifurcation, is afraid about losing a side branch, especially in challenging anatomy. We must know also that any abrupt occlusion of the side branch can lead to an authentic myocardial infarction, and in some cases, a lower ejection fraction and poorer outcomes, even if in the acute setting or in the chronic setting. That's why this occlusion of the side branch after main vessel stenting could happen in 6 to 18% of cases. That's why any operator must learn any strategy to deal with these issues and in order to improve outcomes for our patients. The new EBC consensus document provides many strategies to protect the side branch. When we talk about protecting the side branch, we will talk about baseline wiring side branches and also restoring the flow in the side branch after main vessel stenting in case of occlusion of the side branch. Before we will talk about different strategies, before we develop these strategies, we absolutely need to define what does mean a relevant side branch vessel. In this consensus, we can clearly read that a relevant stenosis, a relevant side branch vessel means that the reference diameter of the vessel is equal or exceed 2 millimeters of diameter. It means also that it supplies more than 10% of the whole myocardial mass, which means also that this vessel is prognosis. In other papers, we can read that if the length of the side branch exceeds 73 millimeters, we can consider it as a relevant side branch, and we need to protect it. But the real message, the relevant side branch, is the one we don't want to lose when we put a stent in the main vessel. What are the risk factors for the occlusion of the side branch after main vessel stenting? For those who perform IVUS before PCI bifurcation treatment, there is a special sign called spiky carina. The appearance of this spiky carina shows that there is a high risk of occlusion of the side branch once we put the stent. For those who use OCT before, this is more simple. When you see here, you can see the lipid content in the atheroma plaque, especially front of the side branch, is a sign that there is a high risk of losing the side branch after main vessel stenting. And finally, in the angiogram, there is many signs that can predict an occlusion of the side branch once we put a stent in the main vessel. As we can see in the left picture, we can see the severe stenosis in the main vessel and the side branch severe stenosis. A wide angle between the main vessel and the side branch is also a high risk feature of occlusion of the side branch. In the other picture, we can see the length of the stenosis in the side branch is also a sign that there is a high risk of occlusion of this branch. We cannot talk about protecting a side branch without talk about jailed wire technique. This consensus reminds us about the old recommendation. The jailed wire technique means that we need to leave a wire in the side branch before main vessel stenting. In the majority of cases, when we do this jailed wire technique, we protect the side branch. But in some challenging cases, anatomies, the side branch can close even we protected by wire. This jailed wire technique can play multiple roles. The first one is that is considered as a marker to recross the side branch through the struts of the main vessel stent. The second point is that jailed wire can play a role as an anchor for the guiding catheter in order to increase the support of the low-profile balloon through the struts of the main vessel in order to open the struts. And finally, this jailed wire can play a role in bailout situation. When we lose the side branch, we can push a low-profile wire, a balloon, sorry, between the stent and the arterial wall in order to open the side branch as a bailout treatment. The new evidence of the use of the jail technique was written in this new consensus, and we can read clearly that in a series of bifurcation complex lesions of CTOs treated mainly by provisional stent technique, when the operator was unable to recross, to protect the side branch with a wire, this was linked to a higher failure procedure and a higher incidence of peri-procedural myocardial infarction. In the COBIS 3 registry, when we protect a side wire, when we put a wire inside the side branch before main vessel stenting, this is what was associated with a significant lower rate of final side branch occlusion in patients, especially in patients with complex bifurcation. And finally, in the EBC main study, the failure to rewire a side branch was associated was frequent when the jailed wire technique was not used. Finally, there is no consensus on each anatomy we should use the side with jailed wire technique, and finally also in case what we need to know if the side branch is closed, is compromised after main vessel stenting, it is recommended to rewire this side branch and open it. So this consensus explain many strategies to protect the side branch occlusion. There is a conventional way and active protection. Two concepts are developed here. The first is the pre-shaped the tip of the wire. This is the way we use every day when we treat bifurcation lesion. We can use a short bend sharp in the distal tip or a wide sharp in the tip of the wire. Sometimes we can use a double shape tip. It depends on the anatomy. If the vessel is large, we can use a wide bend. If the vessel is small, we can use a small one. If this technique doesn't work, you can use the reverse wire technique. This means that we need to perform we need to create two curves in the wire, one in the proximal side and a small one in the opposite side. And we cross the main vessel with a knuckle, which it allowed to the distal part of the wire to cross this tangent anatomy when we have a wide angle between the main vessel and the side branch. When this technique doesn't work, we can use also the dual lumen catheter in this CTO complex lesion. We can cross this dual lumen catheter cross this long CTO lesion. This dual lumen catheter can deliver both wire at the same time in the main vessel and in the side branch, and it can facilitate the rest of the procedure. Another kind of angulated catheter can be used. They call also sophisticated way to treat bifurcation. You can see here a severe stenosis in the ostium of the side branch. It is posterolateral view. And you can see that the P-shaped wire failed to cross this side branch, which is relevant. That's why the use of the angulated microcatheter increased the support and the wire crossed the stenosis with any problem. And also there is a deflectable tip single lumen microcatheter. There is some microcatheter with the distal part we can modify the angulation of the distal part, and it can increase the support, especially in the ostial lesion and when we have some tortuosities. And the final way to prevent side branch occlusion is the balloon block and support technique. And this technique is when the microcatheters are not available or fails to attempt the side branch, we can use this technique and we can inflate balloon in the distal part of the bifurcation. And when the wire is crossing the main vessel, it will go easily to the side branch because the distal part of the vessel is closed by the balloon. Now we talked about baseline wiring vessels, side branch, before main vessel stenting. Now we will talk about rewiring the side branch after main vessel stenting, we can use the same techniques with the same wire, with the same sophisticated technique like angulated microcatheter and deflectable tape catheter, which helped in this case to open the side branch occluded side branch. And finally, there is another way to protect the side branch called the active protection with not the wire gelled balloon, but gelled balloon technique. It was described by Professor Burzota. It means that we put a balloon in the side branch, non-inflated, and we stent the main vessel. If the side branch is open, we pull back the balloon. But if the side branch is compromised, we can inflate the balloon, open the side branch, and remove it again. And we do both at the final way. Here is my last slide. In this CIT resolve trial, they compare active side branch protection and conventional protection with the gel wire technique. And we can see that the rate of side branch occlusion and the decrease in TB flow in the side branch was significantly lower in the active protection strategy rather to the conventional strategy. But the number of periprocedural infection, MI, was the same, particularly in both techniques. And my conclusion is this central illustration, which resume all techniques to prevent the side branch, even prevention, conventional prevention or active prevention, and the use of sophisticated technique to reach the side branch. Thank you for your listening.